It is my pleasure to introduce Noel Eldridge. Noel Eldridge started his career as a contractor at the NASA Life Science Division in 1988, and he went on to work at the National Academies and the American Institute of Biological Sciences. In 2000, he joined the Veterans Health Administration's National Center for Patient Safety as a civil servant. Before retiring from federal employment, which was last November, Noel also worked at the Agency for Healthcare Research and Quality and the Defense Health Agency. The work by the team he led at AHRQ resulted in numerous papers, including the 2022 publication in JAMA that covered trends in adverse event rates from 2010 to 2019. Noel Eldridge will now present on a quick introduction to the CMS Hospital Compare website. Noel, the floor is yours.
Okay, thank you so much for that nice introduction, Kevin. So what I'm going to do during this call is I'm going to go through these slides, but I'm also going to go through web pages and PDFs of the same information. The slides are sort of a backup or something that Kevin can share with other folks that missed the call or whatever. And I wanted to have it organized in here instead of just clicking around through a bunch of web pages live and having you have a hard time tracking it. So the slides just kind of give it a little more firmness and specificity. So this is what I'm going to talk about today. This is the CMS, Center for Medicare and Medicaid Services website, their Care Compare website. We're going to go through the data that's on that website. We're going to focus on the hospital compare part of it. There's other aspects of it. We're going to look at the complications and deaths data. There's other types of data on there. There's a tremendous amount of data on there. I've been tracking this website probably for about 20 years when I was working at the VA when it first came online. And it constantly changes in terms of showing new data, different types of data. And there's also different data that you can download and footnotes, and it gets extremely complicated. I don't claim to fully understand it, but I have a basic understanding of it, and I have a kind of an in-depth understanding on a couple of things related to it. And so I'm going to start off with the CMS Care Compare website. I'm going to show the focus on this complications and death section. This is something that I was looking into in some previous discussions with Helen Haskell, who's on the call. Thank you, Helen, for joining. And we'll see about if we go into this into some further depth after this call. There's quite a lot of information on this website, really more information than any person could really comprehend, because it covers every hospital in this country on dozens and dozens of measures, as you'll see. We'll talk a little bit about the AHRQ patient safety indicator data at the national level, the CMS downloadable data from this website, and then we'll talk a little bit about the Medicare Fee-for-Service versus the Medicare Advantage patients. The only acronym I think I didn't introduce here, this is HAIs, infections, this hospital-acquired infections or healthcare-associated infections. NHSN is the National Healthcare Safety Network that CDC operates, and they develop their own measures that CMS uses. This is text from the CMS Care Compare website. When I've used the text specifically from a website without any changes or anything, I put a little box around it. You can basically see what this says. Obviously, Care Compare is a consumer-oriented website that provides information on the quality of care, et cetera. I'm not going to read this to you. But basically, it covers a lot of hospitals. Like I said, over 4,000 hospitals, all kinds of information. You can go to the website and click on it and click around, and you can find all kinds of things on that website. Now, this is what it looks like when you go to the website. You come to this main page at Medicare.gov, Care Compare. If you don't have the URL, you can just go to Google and say Medicare Care Compare or CMS Care Compare, and it'll get you to this site. Now, you can look at different things like doctors, clinicians, hospitals, nursing homes, et cetera. We're going to look at hospitals. Hospitals are acute care hospitals in this case, hospitals that do all the major procedures and all kinds of care. When you go to Hospital Compare, it'll ask you your zip code or your city, but typically putting in your zip code is the best bet. You put in your zip code, and then it'll say, well, how many hospitals do you want to look at, or how far do you want to look at around your local area? So for example, you can choose 10 miles, 5 miles, 25 miles, whatever. So I put in 25 miles. And so this will show you, if you look on this screen, you can see where I live. I live right around here. And then it's showing me all the hospitals within 25 miles of my house. And so I picked 3 of them to look at. This is the closest one to my house, this Adventist Healthcare. This is another major hospital center. And this is another one. This is just 3 that are nearby, and I picked them out here. Okay. And then you say, okay, well, then what happens? Well, then what happens is that you can ask to see the data. And this is what it looks like when you do that. And it'll give you a heading for each of the 3 hospitals that you choose. You can choose up to 3. You can choose 1, 2, or 3 hospitals. You can't choose 5 or 10 hospitals and get a whole bunch of columns. You can only go up to 3. And it gives you the distance, and it gives you this overall star rating based on all their different criteria. Now, I'm going to try to go to the web page. So this is the live site. So I had the slide where I pasted this up, but I'll go flip back to that in a minute. So this is the live site. So you see I've picked these 3 hospitals, and you can scroll down and it'll tell you all kinds of information on all kinds of different measures here. Patient survey, timely and effective care, complications and deaths. That's the one we're going to focus on in this presentation. Unplanned hospital visits. These are readmissions, maternal health, and so forth. These are mostly put into a plain English type review. So if you're looking for certain measures that you might be familiar with as somebody working in healthcare quality and safety, you won't find them here because they'll have different names. So it can be very confusing at first. You'll be saying, well, where's CLABSI or CAUTI or something, or where's this CAPS measure that you're familiar with, whatever, all these different measures. And you say, where is it? And you can't find it. So you might know these measures by their numbers or their certain names that they have. This is just the patient survey data. But if you know those measures, you're going to have to crosswalk them. And I'll show a little bit about that later on. Okay, so this is basically what you see when you go to the website. Now, when you click on these, you can expand them. And I'm going to do the complications and deaths. And so, but you can basically see that there's a lot of data here for complications and deaths. I'm going to switch back to the slides. So there's complications and deaths, as I said. This is the ones we're going to focus on. There's dozens of measures in here, but we're more interested in these topics. So that's what I'm going to focus on. So there's 3 complications. These are their titles here. Rate of complications for hip knee replacement patients, serious complications, and deaths among patients with serious treatable complications after surgery. I'm going to go into what these are in a little bit, but I'm going to describe what all the complications and deaths are before I go into any detail. There's also infections. They don't call them out as infections in the title, but the complications and deaths includes infections. There's 6 types of infections. There's the CLABSI measure. This is a CDC central line associated bloodstream infection. This is a CDC CAUTI measure. This is surgical site infections from colon surgery, obviously. And then this is 3 other infections, SSIs from abdominal hysterectomy, MRSA, and C. diff. Now, the way the data are shown, going back to the first 3, this is shown as a percent, obviously, rate of complications for hip knee patients as a percent. And then they say whether it's different from the national rate. And they'll show you the national result here, 3.5%. So this 4.4 and this 3.7 are not statistically significantly different, according to them. But you can still see it's higher. If you're going to this hospital, you might say, well, okay, it's not different, but it's still 4.5%. And there are 243 patients at this hospital. So you might be concerned about it. So this here you can see is Adventist Hospital. This is the first column. It's going back to this here. And then you can see this one is really closer to the national rate. For serious complications, this is an OE ratio, an observed to expected ratio. And this is basically the national result is 1. And then higher than 1 is worse. Lower than 1 is better. And then you can see if it's statistically significant by the commentary underneath. Actually, I don't even know if this is a statistical significance test. Sometimes they've had different criteria over the years. I don't know exactly what their criteria are now. Sometimes they put like the top 20% and the bottom 20% and the 80% in the middle. They have got, and sometimes they use like a Z-score based on the number of standard deviations. So I don't remember, or I haven't looked up among all the things I've looked up recently, I haven't looked up what the criteria are for being different. But you can see most of them are different here. No different, no different, no different, no different, no different, no different, no different. So you might say you don't really get too much information out of this because the numbers look different. You know, this is 1, this is 0.79, this is better, but this 0.79 is no different. So you might say, oh my God, what does that mean? This one probably has a larger sample size, but I don't really know why this one is not different and this one is. It's a peculiarity of these statistics that they run. And then this measure, deaths among patients, this 185 out of 1,000, 156 out of 1,000, 149 out of 1,000 with the national result compared to 176. So this is what the kind of thing you can see. And as I said, this is just one of many categories, and this is just 3 of the measures. So you can spend a lot of time trying to understand these measures. The next one are the infections that I showed before. These are also SIRs, standardized infection ratios. They're like this measure here, where 1.0 is the national result, and higher than 1 is above the national number, which is not good. I was going to say rate, but these are not rates. These are rate ratios. So these are dimensionless numbers. So if somebody says, what's the rate? There's no rate. It's 0.432. That's an observed to expected ratio. That could be that the observed is 43% and the expected is 100%. That would be 0.43. Of course, that's a ridiculous number to say 100% is the expected. So say 4.3 is the observed and 10 was the expected. That way it'll be 0.432. Okay, but you don't know what the rates are from looking at these numbers, and you can't know what the rates are from looking at these numbers because they're rate ratios. So it can be very frustrating. And these ones are all this way. All these CDC SIRs are the same way. And you can see, though, that in some cases they're better, some cases they're worse. They're not all the same with these criteria this time. They're not all no different. Then there's 6 things that there's death rates for. So death rates for COPD, heart attack, and so forth. I won't go into further depth on these ones, but you can see what the national number is, like for COPD, 9.4%. You can see 11, 7, 9. All 3 of these are no different. The numbers of patients here, 140, 140. So you might say, if you're looking at this as a patient, you might say, well, national result is 9.4. Well, they say it's no different, but these 2 hospitals both have 140 patients here. One is 11.4%, one is 7.8. The problem is that there's a risk adjustment here, and you don't know if these patients are all 90 years old and these patients are all 60 years old. If that's the case, 11.4 might be actually better performance than 7.8 because these are all 90-year-olds and these are all 60-year-olds. So it's very tricky. So that's why you want to have this no different or better, but it's tricky because you don't know what's going on with these numbers. The numbers are opaque. But there's a lot of data here, as I said. What it means is a little bit tricky to interpret, but the data's here. So now I'm going to go into the 3 complications in a little bit of detail. This is the rate of complications for hip knee replacement patients. This is a CMS developed measure. It's not from any other organization like CDC or AHRQ. And this is one they've developed themselves. This measure, serious complications, is a version of the AHRQ Patient Safety Indicator 90, which is a composite measure based on 10 different patient safety indicators. And this one, PSI 4, is also an AHRQ measure, but it has different data for the CMS population. The CMS population, as I mentioned at the beginning of the call, is Medicare patients. And it's a subset of Medicare patients that are covered by what people refer to as Medicare Fee-for-Service. This is compared to Medicare Advantage patients. Medicare Advantage patients are basically people that sign up for health plans through CMS. It's like an HMO or some other kind of plan where you basically like get a health plan like you are when you're employed. And you have certain co-payments and certain prices for drugs and so forth. When you go with Medicare Fee-for-Service, you have basically a cost sharing with CMS. And, health insurance is a whole area of expertise, not my area of expertise, so I'm not going to go into that in any more detail. But suffice to say, not all Medicare patients are in the CMS sample, but a large number of them are. Another thing from CMS is their downloadable data dictionary that explains all these measures. It's about 100 and something pages, 108 pages or something like that. And actually, it doesn't explain all the measures. It explains them to some extent, but then there's a whole lot of footnotes and things that you have to get elsewhere to try to understand these measures. So it would be an immense job to try to understand them all. The part that we're going to focus in on, the PSIs only apply to Medicare beneficiaries, as I mentioned before, paid through the IPPS. This is another acronym related to the fee-for-service patients. And then CMS takes those AHRQ measures and tweaks them for the CMS population. So the PSI 90, this is another one that we're talking about, the composite. This is the serious complications on the website, but the people that use this kind of data know it as PSI 90 or the PSI composite. On the website, it's referred to as serious complications, which is really obscure. You have no idea what this is. But when you get down to it, this is what it is. It's a composite made of these 10 measures, and they're weighted measures from 2% to 24%. So I don't remember which one's which, but like the hospital fall-associated fracture rate is on the low side, and the pressure ulcers on the high side. So when you add them all up, it adds up to 100%, but the weighting is from 2 to 24. They're not 10% each. So that's another complication of this data. AHRQ puts together a committee to do that weighting. But by the way, as I think about it, we don't even know what will happen in the future because AHRQ has basically been eliminated as an agency in the DOGE process, and who knows if that committee will even exist in the future. Another one is this PSI 4 that I mentioned earlier. Deaths among patients with serious treatable complications after surgery is not included in this measure, but it is on the CMS website, so I'm going to describe it here. As I noted before, the terminology is tricky. This is the CMS data dictionary that I mentioned earlier, and this is the same 10 measures that I have here. And I won't go through them all, but they have different names. So here you can see PSI 3 is referred to as pressure sores. In the AHRQ vernacular, it's pressure ulcers. That's an easy one, but this one is bloodstream infections in the CMS summary, and AHRQ is sepsis, post-op sepsis. So that's two different things. I'm not a doctor, but bloodstream infection is not the same thing as sepsis. I think bloodstream infection is usually considered a precursor to sepsis. So I don't know if they have a different measure that has a different criteria or if they're just dumbing it down for people. So it gets very tricky to try to understand these different measures and if they're the same or different. This is the AHRQ PSI data for PSI 4 and PSI 3. I'm just including this so you can see what it looks like. You can see PSI 4, death rate among surgical inpatients with serious treatable conditions. The denominator for this is only 731,000 in the whole country. So there's only 731,000 people with serious treatable complications, okay? For pressure ulcers, there's 46 million patients in the denominator. Okay, why is that? Because everybody can get a pressure ulcer, pretty much. Not everybody can potentially die from a serious treatable complication after surgery. It's a small number, only 700,000 compared to 46 million. This, I think, is for a year and a half of data. These numbers used to be around 30 million, but for 1 year of data. But now that they upped it to a year and a half as they were following up from COVID, if I remember correctly. PSI 13 is another one that's a component of PSI 90. This is PSI 13, post-op sepsis, as I mentioned earlier. And this one has a different denominator, 7 million. So when you look at these rates, the rates are totally incomparable. So here the rate is 150 per thousand, but only 700,000 denominator. There's 110,000 people in the numerator. This means 110,000 people died after serious treatable complications out of 700,000 patients here. And that's 151 per thousand. And there's numbers here for the different age groups and so forth. Here, there's only 32,000 out of 46 million. The rate is 0.7 per thousand. So you might say this is 151. This is 0.7. This is like 200 times higher. So this is happening 200 times as much. No, it's only happening 3 or 4 times as much because 32,000 versus 110,000. So these rates are totally incomparable. You cannot compare these rates. They don't mean anything except for the denominator that goes with them. And then looking at this last one here, this denominator is 7 million, and the numerator is 32,000 again, like this one. Here, 32,000, 32,000. Here, the 32,000 is a 0.7 per thousand. Here, the 32,000 is 4 per thousand. You say, what does that mean? Well, the denominator is 7 million, so 32,000 out of 7 million is 4 per thousand. So you can really drive yourself crazy if you don't understand what these things are all about. The denominator ratio for these three measures is about 1 to 10 to 63. So the denominator is quite different. Okay, that's the AHRQ background data. The CMS data can be downloaded from this site, the data that's on the Hospital Compare. The data I showed you from AHRQ is not on Hospital Compare. That's just background for what these data look like. Now, when you go to download all the data sets, it turns into a crazy situation. There's dozens and dozens of files here. I don't expect you to read this. I'm just showing you that there's a whole lot of files to look at. I've started looking into these, and I'm going to go into them just a little bit. This is the CMS data dictionary that I mentioned earlier, and I put this up here just to let you know what it looks like and where it's at for download. Now, this is what the CMS data looks like. You can see here, when you go to this Excel spreadsheet, some of these spreadsheets are tens of thousands of rows long and many columns wide. This is just a subset here. So this is the PSI 3, 4, 6, et cetera, down to PSI 90. This is for a particular hospital, one particular hospital. And you can see the denominator is here for the hospital. So you can see they have around 6,600 in the denominator for the pressure ulcer rate. That means they had about 6,600 discharges for this period of time. So if I was remembering correctly that this is for a year and a half, that would be around 4,500 discharges. It's a pretty decent sized hospital. Actually, this one's even higher, the in-hospital fall-associated fracture rate. So there are some exclusions from this measure. You can see these denominators vary quite a bit. This is the full up largest denominator, about 8,400. Anybody can have a fall in the hospital. I guess not everybody can have a pressure ulcer. There's some exclusions from that. Maybe people that are admitted with pressure ulcers may be excluded from this measure. I can't remember what all the exclusions are off the top of my head. And you can see everyone, as I said before, has a different denominator. But unlike the AHRQ data that I showed you earlier, there's no numerator here. There's no numerator. So here's the people that could have had a pressure ulcer, people that could have had a fall with a fracture, people that could have had a postoperative wound dehiscence, et cetera. But there's no numerator that you can turn into a rate. There's just these scores. These are risk-adjusted scores. You can see the scores here. 3, then there's a lower bound and a higher bound, 1.6 to 5.5. And so these are compared to national rates, presumably, and then you can say if they're different or not different. But I can't remember, or I don't know what these criteria are for the lower and the higher estimates. There might be 2 standard deviations or something like that. So this one is another one, but this one is interesting because the HAI data, which is based on CDC data, it is apparently unadjusted. When you look at it, I looked at it carefully and I started playing with it and I saw that you could do the calculations on some of these. I have a little zoom up here, but basically you see all 6 measures: central line associated bloodstream, CAUTI, urinary tract infections, colon surgery infection, abdominal hysterectomy, and so forth. And then there's just a little zoom in on one section. You can see what I did to actually calculate a rate here. Because, as I said, when you go to the actual website, you don't get any rates. You just get the SIRs, which are the rate ratios. So for central line associated bloodstream infection, you can see the number of device days, 8,926. And then you can see the number of infections, 5. Well, if you do the arithmetic, it comes out to 0.56 per 1,000 line days. So I did that in Excel. But it calculates out 5 over 896 times 1,000 is 0.56. Here, same thing for the CAUTI, 4 per 15,000 catheter days. I said line days for both of them. This could be catheter days, 0.26 per 1,000. And then in this one, I didn't show it, but you can calculate it as a percent. For colon surgery, this hospital had 2.2%, which is extremely low for colon surgery infections, 5 out of 228, and so forth. So I calculated these other ones. So let me just give you a little bit of background about what the data are taken from, and then I'll wrap it up. So this is the Medicare Fee-for-Service, or IPPS system. And when you think about it, as I mentioned earlier, you might say, what does that mean? Who are these patients? I know Medicare patients, they're generally 65 and older. plus some other patient groups such as people on end-stage renal dialysis, end-stage renal disease. But beyond that, who are these Medicare patients? So it's a little tricky. Medicare, these are ones that go into the CMS data that we saw here. Who's going into this sample? So it's a sliding scale here. You can see this is the Medicare Advantage trend. I took this from the Kaiser Family Foundation website. And you can see that Medicare Advantage, which is like an HMO, I'm simplifying it, or health plan type measures. There's lots of them to choose from. I just went through this with my parents last year, changed them from one plan to another based on some recommendations from friends that they knew. And you can see the Medicare Advantage has gone from 19% to 54% over the last 17 years or so. So this is a huge thing. I mean, it's gone from like 1 in 5 to more than half the patients, slowly creeping up. Now, one thing that I know going back in time from my own personal experience working with AHRQ is that it wasn't the same in every state. And it's still the case now. You can see this is the percentages. This is from the Kaiser Family Foundation. This is some of their data. And you can see this is data for 2024. They also have the data for 2014 on the site. But you can see Wyoming is under 20% and Florida is over 60%. And then a place like where Virginia is around 40 to 50%. So you say, oh, well, this is kind of a weird patchwork. Well, it's even a weirder patchwork when you look at the counties. So like in New York, some counties here are over 60%, and then up across the other side of the state, they're around 40 to 50%. And then some part of the state down here, this is where I'm from, New York originally, it's like 30%. So the penetration varies a lot. You know, not all these counties have similar populations, so it can be tricky, especially in a state like New York, where some of the counties might have 2 million people, other counties might have 20,000 people or something. But nonetheless, you can see there's a lot of variation on Medicare Advantage penetration. So that can really make you wonder what the Medicare Advantage data mean. So this is something I found from the Commonwealth Fund from 2021. So you can see they've had different characteristics. Black and Hispanic patients and those with lower incomes have tended to enroll in Medicare Advantage, maybe because the plans have more easily predictable costs than the Medicare Fee-for-Service. You know what things are going to cost a little more easily, like when you're in a health plan. That's been the way it's been in the past. But looking at it now, the data from the same website, this is the traditional Medicare, like the Medicare Fee-for-Service. This is Medicare Advantage, the first two bars. These are the special needs patients. These are like the end-stage renal disease kidney patients and some others that qualify. And you can see these first two bars are pretty similar for chronic conditions, arthritis, cancer, heart failure, COPD, diabetes, depression. So the two population groups seem to be becoming more similar, but you know, this is at the same time as you look at these counties, there's a lot of variation. So it does make you wonder exactly what it all means when the sample is maybe different from one state to another. If you look at state data, or if you look at hospital data, you're only getting the fee-for-service patients from those hospitals. If people are mostly on Medicare Advantage at that hospital, if they're 60% on Medicare Advantage, then you're only seeing the data for the 40% that are not on Medicare Advantage. And are they richer or poorer patients? Are they more well-educated? Are they less well-educated? You don't know. So it's pretty tricky to interpret. Okay, so that's the end of my slides. And this is one of my favorite quotes. Not everything that can be counted counts, and not everything that counts can be counted. But let's still take a shot at it for the things that we think do count, which is what we've tried to do, what I've been trying to do for the last 24 years before I retired. And this is just a little comment. Who knows what the staffing and funding and organizational changes are going to mean? The CMS and AHRQ, they're getting cut pretty severely in certain groups. And who knows what will happen in terms of the ability to keep generating this data, having these committees meet, update measures, things like that. And that's it. My email is here. And you can also find me on LinkedIn. Evan, hope that was useful.
Yes, it was very useful. Thank you very much.